So I shall start the session now. I think we are already running late. Good morning to all. So the finals of this free paper for the pediatric and Squint. So our chairperson is Dr. Prempal Kaur. Dr. Vidya is our co-chairperson. I myself, Dr. Kshitij, and Dr. Sonia is our co-convener. So, not giving out any time, sir, with the permission of the chairperson, shall I start the session, ma'am? Yeah. So the first chief and presenting author, so the paper is FP91, Refractive Shifts After Corrective Surgery in Non-Paralytic Strabismus. Dr. Avinash, please. So, Dr. Avinash, I think you must be fully aware that you have 5 minutes and please adhere to the time limit, okay?
Yes, sir.
Okay.
So, good morning, everyone. So, the refractive shifts after corrective surgery in the non-paralytic strabismus. Introduction: strabismus surgery, particularly horizontal rectus muscle recession and resection, is a well-established corrective intervention for ocular misalignment. Where the primary goal is alignment improvement, the procedure can translately alter the biomechanics of the globes, thereby affecting the corneal curvature and refractive status. Under the following headings, we will talk. The known effect is the strabismus surgery on the horizontal recti is associated with the transient refractive changes, most notably a myopic shift and with the rule astigmatism in the early post-operative days. In my study, there is a refractive changes typically peak in the first months of the post-op periods and regress toward the baseline after 3 to 6 months, indicating this is a temporary phenomenon. The previous studies have been limited by small samples, inclusion of both vertical and horizontal muscles, and inconsistent evaluation for the role of the surgical dose in refractive. In my study, we are focusing solely on the horizontal rectus surgeries. The present study aims to clarify the magnitude and the course of the refractive changes and assess their correlation with the extent of recession and recession. The aim is to evaluate the change in the spherical equivalent and the astigmatism and to study the correlation between the surgical doses in recession and resection of refractive changes. It is a prospective interventional study conducted over 1 year of time in a tertiary care center. Inclusion criteria: patient is between the 6 to 35 years, in which we only do a horizontal strabismus requiring unilateral or bilateral horizontal rectus muscle surgery. There is no in which there is no previous ocular surgery and in corneal pathology with normal anterior segments. In inclusion, we exclude the oblique muscle surgery and corneal pathology, amblyopia with BCVA worse than 618, and any systemic connective tissue disorders. In preoperative evaluation, we take a best corrective visual acuity with cycloplegia refraction and mean keratometric changes values. In surgical technique, the standard Fornix approach was used. The amount of muscle recession or resection was determined per standard surgical nomogram. All surgeries were performed by the same surgeon to minimize the technical variability. In post-operative surgery, day 130 and 90s were evaluated with BCVA, cycloplegia refraction, and mean keratometry. We found a total of 57 eyes of 32 patients were included, with 31 undergoing recession and 26 eyes were undergoing recession of horizontal muscle recession. The mean age of participants were between 12 to the mean was 12.6 with male to female ratio were approximately 1:2 to 1. The results: there is a transient shift in the myopic, which shift in the myopic which is greater in recession, that is the blue line, which partially regressed by the day of 19. In astigmatism, we also have, get a result of there is a transient shift in the astigmatism which peak at the day 1 and which also regress back to the baseline. There is no in scatter plot we can there is no correlation between the surgical dose and the magnitude of the myopic shift. The result of the study, a prospective study, demonstrated that the horizontal rectus muscle surgery produces a measurable but transient myopic shift with the rule astigmatism in the early postoperative day. The changes were more pronounced in the recession group compared to the resection, peaking around the 1 month of postoperative and generally returning base to the baseline of the 3 months. There is no statistical significant correlation between the amount of the recession and resection and the magnitude of the refractive changes at the 4 to 6 weeks. For patient care perspective, the transient nature of these refractive changes reinforce the importance of delaying definitive post-operative spectacles prescription until the stabilization was achieved, ideally at 6 to 8 weeks. Patient and family should be in counsel preoperatively regarding the possibility of the temporary visual fluctuations. This is especially relevant for the school-aged children, where the unnecessary spectral changes could lead to the cost and compliance issue. In horizontal rectus muscle surgery induces a transient myopic shift, and with the rule estimated with the effect more pronounced in the early undergoing recession than the resection. These changes peak within the first week post-operatively and generally resolve by 3 months, returning refractive state close to the preoperative baselines. The magnitude of the refractive shift does not show any significant correlation with the amount of the muscle displacement, suggesting that the temporary biomechanical and wound healing factors are more influential than the surgical. Thank you.
Thank you, Dr. Avinash. So you have completed within the time limit. So I would ask the chairpersons if they have any questions for the speaker. No? Only one point, Dr. Avinash, just to keep the slides at this stage, whenever you are presenting it, keep it concise and you don't have to read so much of the material. Keep it in bold and what you are highlighting. We cannot read all the points in detail. Okay, fine. Thank you. So the next author is Dr. K. Santangopal. He will be presenting why orthoptic for strabismologist and general ophthalmologist.
Good morning. I don't know how many of you are aware of orthotic, but it is a simple instrument which is based on the fact that when M cells and P cells are sequentially stimulated, it leads to stimulation of occipital cortex, frontal cortex, and parietal cortex. The vision is not a function of just occipital cortex. Occipital cortex is what I call it as Manmohan Singh of the brain. It doesn't do anything to the visual impulses, it just forwards it to the high command. The high command being the parietal cortex and frontal cortex, which analyze the impulses sent to them and send back the information to the occipital cortex. While sending back the information to the occipital cortex, from the parietal and frontal cortex, there come what is called as the top-down impulses. These top-down impulses are recognized in the EEG as alpha and beta oscillations, and the impulses going from occipital cortex to inferotemporal cortex is recognized as gamma impulses. So the top-down impulses fast forward the impulses at the occipital cortex and thereby improve the vision in a rapid manner in amblyopia and also improve the motor control in a number of cases. That's why it's important in treating not just amblyopia, but also important in treating sixth nerve palsy and in fourth nerve palsy. So I will not go into the details. It's just to know that it's very easy to set up the machine. Even a child aged 4 years can use the machine, and it's very useful in treatment in reversing some of the squints, particularly the intermittent divergent squint, and reduces the amount of esotropia, and also exotropia is completely nullified with this instrument. It's easily available. There are many indications, as I told you earlier, amblyopia of all types, and particularly the anisometropic amblyopia, and it's also useful in fourth and sixth nerve palsies, in dissociated vertical deviation and recurrence of XT after surgery, and in nystagmus and some cases of optic atrophy. Some of my people who have bought the machine, they have told me it is useful in optic atrophy. There's a very complicated mechanism. I can explain to you outside. And post-squint surgery, where the movement limitation is not due to muscle slippage, but due to other causes, it responds very well. If it is due to muscle slippage, you have to operate. So it's useful for general ophthalmologists and strabismologists equally. Financially viable because many ophthalmologists have recovered the initial investment within 6 weeks of buying the instrument. And the following video shows how to set it up. It's very simple, fix it on a wall, and how to use it is like this. And the child is given a laser pointer which he points out, and it improves the hand-eye coordination. The hand-eye coordination improves because the hand area in the brain is situated very close to the frontal eye field area. So when the eye moves, the hand is stimulated. When the hand moves, the eye is stimulated, and the top-down effects will be on the foveal area in the brain. You can see a child aged 4 years give chips in one hand, and you can see that holding the chips. I said you do it for 10 minutes, you can eat 2 chips, and the child does it, and adults can. This is the response of some of the users. They said it's a wonderful gadget, and I have never experienced the results like this in the past. And to know why it works, it's the most complicated, and this figure explains to you why it works. The P cells and M cells, although they are contiguous in the retina, they are not together in the brain. In the brain, they go to different parts of the brain, and they are analyzed for different reasons. The P cells analyze the color, shape, size, structure, and surface of the object. The M cells analyze the motion and the spatial location of the object. And these two are connected to each other, and we make use of this connection in the brain between M cells and P cells, leading to repeated use of M cells, which stimulates the P cells, and the P cell stimulation removes the obstacle which is at the 4C beta in the brain. In the V1, the obstruction is at the level of 4C beta, whereas the M cells go to 4C alpha. So stimulation of M cell 4C alpha leads to stimulation of parietal cortex. The stimulation of parietal cortex in turn leads to stimulation of occipital cortex, and this is an alternative pathway we make use of in stimulation of amblyopia. And that should, I am the inventor, I have financial interest. Thank you very much.
Thank you, sir. You have taught us so many things already throughout the years. So thank you so much for still doing that. And I don't think so.
Okay.
So proceeding forwards, Dr. Sheetal is there. Yeah. So she will be presented on miniplication, untapped surgical treatment to treat small angle residual strabismus.
Good morning, everyone. I'm Dr. Sheetal, and I'll be presenting on miniplication, the surgical treatment for small angle residual strabismus. Our chief author and chief surgeon is Dr. Deepti Joshi, ma'am. So we have nil financial disclosure. Any deviation less than 15 prism diopters is called a small angle deviation, and normally our divergence and vertical fusions cover up to 4 to 6 prism diopters for divergence, and vertical versions cover up to 2 prism diopters. Anything more than that has to be corrected, and usually the conventional surgeries that we do overcorrect the small angle strabismus. But why to correct these small angle strabismus? Mainly it's the diplopia in adults, and they are very much amblyogenic in children, and in few cases they cause cosmetic blemish. So in previous studies, we have known that small angle strabismus can be corrected non-surgically through prisms and surgically through tenotomy, marginal myotomy, and miniplication. Usually, tenotomy and marginal myotomy are the most common surgeries that are done, but they correct only up to 4 to 5 prism diopters. So the miniplication was first described by Kenneth et al. Sir, and the primary surgery corrects about 5 to 7 prism diopters, whereas secondary surgery in already recessed eye in antagonist muscle, it corrects around 8 to 10 prism diopters of correction. So we aim to evaluate the efficacy and outcomes of miniplication on a rectus muscle to correct small angle residual strabismus. We enrolled 14 patients who were post-surgically residual small angle strabismus, and who were symptomatic. They had diplopia or they were at the amblyogenic age group, and who were too small for conventional surgeries. We excluded the restrictive strabismus cases. So we went through details, demographic details, previous surgical histories, complete comprehensive eye evaluation was done, diplopia was charted, and strabismus measurement was done. So in the miniplication, what we do is we take a suture at around on the muscle belly over 5 millimeter behind the insertion, and we bring it anteriorly, just anterior to the insertion of the rectus muscle. And that's it. Seems very small. Small, simple procedure for a small angle strabismus. So we followed up for 2 years, descriptive statistics was done, and any value, any p-value less than 0.01 was considered statistically significant. And we considered our surgery to be successful when there was a resolution of diplopia, deviation of less than 5 prism diopters. So in our cases, among 14 patients, 11 were males, 3 were females with a mean age of 26 years. 8 had already undergone bilateral LR recession for exotropia. 5 had gone bilateral MR recession for esotropia. 1 had hypertropia, who was a post-IOS recession. These are my results. And the pre-op value of 9.86, the average 9.86 was corrected up to 1.57. It was a residual that we have got. And the average correction per muscle was in lateral rectus, it was around 8 prism diopters, in medial rectus around 7, and vertical rectus around 6 prism diopters. These are the post-op photos. The 8 patients who had preoperative diplopia was corrected completely, and there was no overcorrection in our cases. So residual squint is a common scenario after strabismus surgery. Small angle strabismus do cause diplopia and are embryogenic. So patient who want spectacle-free option, the surgical intervention comes to the rescue. Usually we have 2 options, marginal myotomy or tenotomy and mini plication. Why not marginal myotomy? First of all, like I said, it corrects only up to 5 prism diopters, and it is already done in a recessed muscle. So it is difficult to expose already a recessed muscle which has hemorrhages and adhesions, and there are causes of overcorrection. It is little unpredictable. And in our case, in mini plication, we do it in a de novo muscle, and it is reversible, and average correction is around 9 to 11 prism diopters, and the best part being the ciliary vessels are spared. Limitation of our study was only 14 patients, so it was a smaller sample size. It needs an extended follow-up. And do we have to do a graded plication? Yes, we do only 4 to 5 millimeter of plication. So we have not graded it according to the pre-op deviation. So I would like to extend this research further. To conclude, mini plication is a very safe and efficacious part. Small angle strabismus can be dealt with, especially with diplopia and amblyopia. And why not prisms? If patients are undergoing LASIK surgery to get rid of spectacles, and why not surgery to get rid of prism glasses, right? Yeah, thank you. These are my references.
Thank you, doctor. It was nicely, very concisely presented with all the good contents and everything. So you have not left many questions for us. I think most of the things you have answered in your slides itself. So I will just ask the chairperson, say if any questions, anything we wanted to ask.
Thank you, ma'am.
Yeah.
Thank
Okay.
you, sir.
So moving ahead, Dr. Shalu Bhagat for surgical management of double depressor palsy associated with exotropia.
Good morning, everyone. I am going to present a case report of double depressor palsy with exotropia, a novel surgical approach. There is no any financial or conflict of interest to disclose. Double depressor palsy is a rare entity characterized by unilateral limitation of depression caused by IR palsy. Usually a sporadic congenital disorder, however, few acquired cases have also been reported. Acquired cases include orbital muscle trauma to cerebrovascular events affecting bilateral thalami and viral neuromyelitis. Differentials include traumatic blowout fracture with IR entrapment, primary secondary SR contracture, thyroid eye disease, CFVM, and myasthenia gravis. Surgical techniques described include SR recession for SR contracture and inferior transposition of horizontal recti, that is inverse NASP procedure. This is a 35-year-old male presented with chief complaint of upward deviation of right eye since age of 6 years and outward deviation of right eye for last 25 years. There was preceding history of fall from stairs at the age of 6 years, and best corrected visual acuity was 612 in right eye and 6.6 in left eye. Cycloplegic refraction showed no refractive error, and on Begalinis, the right eye suppression was noticed, and hence no stereopsis for distance and near. No significant findings were discovered over slit lamp examination and fundus examination. On Prisma cover test, the left eye fixating, there was right eye exotropia of 45 prism diopter with hypertropia of 35 prism diopter. There was limitation of movement in down gaze. We can see horizontal strabismus was almost equal in both primary and secondary deviation. and vertical strabismus is more in secondary deviation. And we can conclude the pathology is in right eye, and on dextral depression there is more strabismus, thus inferior rectus is involved. Differential diagnosis is right eye acquired double deep pressure palsy with secondary SR contracture with exotropia, CFEOM, and thyroid eye disease. So, forced Jackson test was done positive for superior rectus, and forced generation test was done which was negative for inferior rectus. Routine blood investigation was normal, thyroid function was normal, and MRI brain and orbit was also normal. Probable diagnosis include right eye acquired double depressive palsy with secondary SR contracture with exotropia. So first stage surgery was done for superior rectus contracture, and a recession of 7 mm was done. After stage 1 there was residual of 25 prism diopter of hypertropia and 45 for exotropia. In second stage, LR recession 9 mm plus MR plication 6.5 mm along with IO recession and anteriorization 1 mm anterior to temporal insertion of IR was done. And after stage 2, I was orthotopic in primary position, post of 1 week and post of 6 week. Discussion surgical options include inferior rectus recession, inappropriate in our case because FGT was negative for inferior rectus. Inverse NAS procedure would only correct hypertropia in affected eye and will also require other eye surgery to correct horizontal squint. Partial tendon inverse naps with resection plication of superior half optimal correction and of hypertropia and exotropia only up to 25 prism diopter. We went for procedure never described for double deep pressure palsy. Recession and anteriorization of IO was done with recession plication of horizontal recti. It alters the functional insertion of IO and muscle, transforming it into depressor from an elevator. Traditionally, recession and anteriorization of IO is usually done for IO overaction DVD and isopalsy. This procedure successfully treated both exotropia and hypertropia without need of surgery in other eye. And drawbacks only of IO anteriorization is anti-elevation effect, but post-operatively our patient had fared to good bells. Conclusion, double depressor palsy is rare entity, may present with exotropia in long-standing cases. IO recession and anteriorization with horizontal muscle surgery is good alternative for double depressor palsy with exotropia with satisfactory surgical outcome, and it reduces the need of surgery in unaffected eye. Thank you.
Thank you, Dr. Shallow. So, this is one of the problems with the double deep pressure palsy, especially when presenting with exotropia.
Yes.
So, I will ask the chairpersons if there is any question for the speaker. Okay, so we'll go ahead. Yeah, just a second. Dr. Shallow, just a second. Yeah, no, it's fine.
What was the duration of time between the first stage and second stage surgery?
3 months.
Okay.
Okay, thank you, Dr. Next, Dr. Panisha Gupta. She will be presenting to assess the surgical outcome of true muscle transplantation in large angle horizontal strabismus. Okay, go ahead.
Good morning, everyone. Today we are discussing.
Just a second, Dr. Panisha. Can we reset the timer also? Yeah. Go ahead.
Good morning, everyone. Today we are discussing a study to assess the surgical outcome of the true muscle transplantation in large angle horizontal strabismus. Large angle strabismus is defined as deviation more than 50 prism diopters. It has a significant negative impact on the patient's cosmesis, confidence, and the lifestyle, and also its management present the unique challenges. Conventionally, we doing the horizontal strabismus is treated by surgical recession and resection, but in the cases of the large angle strabismus, it usually leads to recurrent or the residual deviation, and the patient has to undergo multiple or bilateral surgeries, for which patients are often reluctant to undergo. True muscle transplantation is a simple technique to deal with these unique challenges. As we can see in this picture, in this we take a resected segment of the one muscle and it is transplanted to the other muscle for its recession. By this increases the effective length of the muscle, thereby reducing its power, and the globe changes in its primary position. Aims and objectives of our study is to assess the visual alignment after true muscle transplantation in large angle strabismus and to measure the residual strabismus as well as any residual extraocular muscle restriction after the large angle strabismus. Our study includes the sample size of the 15 patients. Inclusion criteria: patient age 16 to 50 years with large angle strabismus more than 50 prism diopters, and patient age 16 to 15 with recurrent or residual strabismus more than 50 prism diopters. Exclusion criteria: patients having horizontal strabismus less than 50 prism diopters and patients having age less than 60 or more than 50 years. So coming on to the results, these are our baseline parameters of our study. Average pre-op deviation in all our cases were approximately around 83 prism diopters, and average post-operative deviation after doing the true muscle transplantation was approximately around 5 prism diopter. We defined this success as the deviation of less than 10 prism diopter, which was achieved in 11 out of the 15 patients, and the post-operative residual deviation was more than 10 prism diopter in 4 cases, which was due to undercorrection. So the post-operative muscle restriction was present in total 5 cases, out of which 3 were of the exotropia and 2 were of the esotropia on post-operative day 1. But at the 6 weeks post-operative, 6 weeks of the post-op, there is only 2 cases of esotropia in which muscle restriction was present. So as we can see in this graph, restriction in esotropia on postoperative day 1 is present in the 2 cases is of the -2, and at the 6 weeks restriction is present in the 2 cases, one is of -2 and other one is of the -1. And the restriction in exotropia on post-op day 1 is present in total 3 cases, 2 are having the -3 restriction and 1 is having the -1, but at the end of the 6 weeks there is no exotropia cases having the restriction. Correction achieved by the transplanted segment is approximately around 29 prism diopters, but the correction achieved by the per millimeter of the transplanted segment was around 6 prism diopters. So, large angle deviation, conventional recession and dissection calls for bilateral surgery, for which many patients are reluctant to undergo. True muscle transplantation is a safe and reliable procedure in which only a single eye is operated. It has an added advantage of the effect provided by the transplanted segment, which was around 6 prism diopter per millimeter of the segment. So it is a simple technique, uniocular surgery having the good cosmetic post-operative alignment and the minimal restriction of the ocular motility. Thank you.
Okay, Dr. Panisha. So I just asked the chairperson, and is there any question? I just have one answer. Is there any other complication that you have not mentioned in your study of muscle transplantation?
Sir, basically we are taking the muscle from the same eye, so it has an added advantage that it retains its contractile property, and also it's a biocompatible tissue and easy to use. The main limitation of our study was that the sample size was less. It was around 15 patients, and we have done the follow-up up to 6 weeks. So we are expecting that the long-term follow-up is मतलब long term में we are following the patients so that results are monitored more closely.
Oh, that is good enough. But what I am asking is there any other problem with the muscle transplantation? Is there any complication or any other thing that you have forgot to take in this, or you have not noticed?
No, sir. In our 15 cases, the main results were that there is residual deviation in the 4 cases and the muscle restriction was present.
So no, that was the result that you were hoping for. I'm asking that whether any other untoward side effect or any other complication that you have not mentioned in this surgeries.
So maybe it can lead to the reversal of the squint. That is, if patient is having the esotropia, then due to the undercorrection or overcorrection.
Oh, that is there. The surgery you are measuring and doing it, but you are transplanting a part of a muscle from one part to the other. Are you having any other problem with this? No.
Sir, in our surgery we are not having problem.
No. Okay. So the other thing that I just wanted to ask, because the time is very short, that you have you used it? How much have you graded it? How much muscle transplantation has to be done?
Yes, sir. According to case wise, we have graded it. We in this scenario, we only present the average segment. That the
Okay.
total fragment was taken up, corrected up approximately around 30 prism diopter. So, like in exotropia and esotropia cases, in exotropia cases, the segment we get was approximately around 3 segment, and in the esotropia cases, the segment we get around 4.5
Okay.
segment, because in exotropia cases we are taking the segment from the MR, and in the esotropia cases we are taking the segment from the LR. So the MR segment is lesser, and the length of the LR
LR is less.
is more, so the segment is more.
Okay. Thank you. Good enough. So moving ahead, Dr. Shreya Jaggi is there? No. So one more presentation is there on the back, in the final page. ROP is there. Dr. Jasneet Kaur. So she's also not there. So I think we are to conclude this session now and just complete the tabulations with all my, yeah. So I think we are done with the session now.